Hey everyone, welcome back to my channel Dental Cafe. So today we are going to discuss about the pulpotomy part 2, pulp therapy in pediatric dentistry. Part 1 was already discussed. Okay, then begin with the part 2. Brief about the pulpotomy, that is what is pulpotomy. So it was given by the Finn, who defined it as the complete removal of coronal portion of the dental pulp followed by placement of dressing or medicament that will promote healing and preserve vitality of tooth. It means we are only going to remove the coronal portion of the pulp, not the radicular portion, so that the vitality of the pulp should remain there. So what is coronal portion of the pulp? Look at the figure. This is we have a coronal portion of tooth and this is apical portion of tooth. In pulp, we have coronal portion of pulp and the radicular or the apical portion of the pulp. As you can see in the figure, caries is just approaching the one of the pulp horn. In such cases, we are going to perform the pulpotomy, either partial, either a complete pulpotomy. Now the classification, we have two types of pulpotomy: vital, non-vital. In vital, we have devitalization, under which we have a mummification and cauterization. Then we have a preservation and regeneration. Under non-vital or mortal, we have beechwood cresol and the formocresol, was already discussed in part 1. Begin with the partial pulpotomy. So, what is partial pulpotomy? Partial pulpotomy for traumatic exposure is a procedure in which the inflamed pulp tissue beneath an exposure is removed to a depth of 1 to 3 mm to reach the deeper healthy tissue. So look at the figure. We have a carious portion involving a part of coronal pulp, not the complete coronal pulp. So what we are going to do, we are going to remove the inflamed pulp with depth of 1 to 3 mm so that we can reach the healthy tissue. Once the healthy tissue of fresh bleeding start appearing, then we are going to close with the dressing. Now, after removal of the coronal or the part of coronal or the carious pulp, we are going to place a calcium hydroxide or mineral trioxide aggregate dressing. And then we are going to put a temporary restoration. All the steps after placing calcium hydroxide are same as that of the other type of pulpotomy. We are going to place a temporary restoration and then wait for a week or a month, and then we are going to take a x-ray. If there is a sign of calcification, then we are going to place a permanent restoration and then metal crown. So, indicated for vital, traumatically exposed young permanent tooth. Very important. Only for young permanent tooth with an incompletely formed apex. So, what is the meaning of traumatically exposed? Traumatically exposed mean you are going to restore a deep carious tooth which is close to the pulp and accidentally pulp exposed. So, this is we call traumatically exposed. Now begin with the mortal or the non-vital pulpotomy. So what is non-vital pulpotomy? Ideally we all know non-vital tooth should be treated by a pulpectomy or a endo treatment. But young permanent, in case of young permanent tooth, we are going for non-vital pulpotomy instead of pulpectomy. Why? Because due to non-negotiable root canals and are also due to limited patient cooperation. So we are going to perform a two-stage pulpotomy. Okay, and what is this two-stage pulpotomy? Let's see. So this non-vital pulpotomy is performed in two appointments. So what we are going to do in first appointment? So look at the figure. This is we have a necrotic pulp. A part of pulp tissue become necrosed. Now, first of all, we are going to remove the necrotic pulp with the help of spoon excavator. Very gently. Okay, do not use air rotor or anything else. Very gently we are going to scoop out the necrotic pulp. Then we are going to place a cotton pallet we are going to irrigate the pulp chamber with the saline and dry it with the cotton pellet. Now, after drying with the cotton pellet, we are going to dip the cotton pellet in beechwood cresol and place it over the radicular pulp. And then we are going to seal the cavity with temporary cement for 1 to 2 weeks up to 1 month. This is what we have to do in first appointment. Now, second appointment. After 1 to 2 weeks, we'll call for the second appointment. What we will do in second appointment, we are going to remove the cotton pellet dipped in beechwood cresol. We'll remove that cotton pellet. If sign and symptoms persist, then we'll repeat the treatment. Otherwise, or extract the tooth. And how we'll check the presence of sign and symptoms? If we are going to remove the cotton pellet, there is a bleeding, or we are taking a x-ray, if there is a changes in the apex, then we are going to remove or extract the tooth. If no symptom, if no symptoms, then pulp chamber is filled with antiseptic paste, and then it can be restored with SS crown. ऐसा ज़रूरी नहीं है कि हर बार सिम्टम चला जाए. इट वरी फ्रॉम पेशेंट टू पेशेंट एंड द टाइप ऑफ माइक्रो ऑर्गेनिज्म. So sometimes there may be a symptom. Sometimes symptom may persist. So in such cases we have to extract the tooth. Now, what is laser pulpotomy? So we will talk about the laser pulpotomy in just brief, because you have to expect only 2 questions in competitive exam from this topic, laser pulpotomy. First question they can ask, who introduced laser pulpotomy? So it was introduced by the Zhang Fan Liu et al. In 1999. And which type of laser they used? They used argon laser for pulpotomy in primary tooth. Now, electrosurgical pulpotomy. What is this? So it was given by Mack and Dean in 1993. And this is a non-pharmacological technique. We are not going to use any medicine in this technique. After amputation of corneal pulp with the electrosurgery, the pulp stem are cauterized. We are using electrodes to cauterize the pulp stem. We are not going to use any kind of medication or dressing in electrosurgical pulpotomy. After completion, the pulp chamber is filled with zinc oxide eugenol paste and then restored with SS crown. Preservation type of vital pulpotomy, under which we have glutaraldehyde vital pulpotomy given by Coppel in 1979. Superior fixation by cross linkage. Diffusibility is limited. Glutaraldehyde have limited diffusibility, excellent antimicrobial agent, and causes less necrosis of pulpal tissue. So we can also use glutaraldehyde as a dressing agent. Ferric sulfate form a ferric iron protein complex that mechanically occlude capillaries. It blocks the capillaries. Less inflammation than Formocresol. 92.7% radiographic success rate. Now the last one, we have regeneration. An ideal pulpotomy treatment should leave the radicular pulp vital, healthy, and completely enclosed with an odontoblast lined dentine chamber. Ideally, we should leave the radicular pulp in case of pulpotomy so that vitality of the pulp remain maintained. But what we are going to do in regeneration type of pulpotomy, we are going to place a bone morphogenic protein which contain a factor capable of autoinduction of reparative dentine formation. It contains an osteogenic protein that causes the induction of reparative dentine formation. I hope this video is helpful for you to understand what is pulpotomy. All other type of pulpotomy was discussed in part 1. I will share the link. And don't forget to like, share and subscribe my YouTube channel and hit the bell icon for the latest update.